Hi, my name is Kate Grossman. I'm a Pulmonary and Critical Care Fellow at Mount Sinai Medical Center in New York City.
Hi, my name is Glenn Chun. I'm one of the Senior Fellows at Mount Sinai in New York City, and I will be assisting Kate today with this video. There are three parts in properly placing a sterile venous catheter: pre-procedure, procedure, and post-procedure care. Once you have decided a patient requires a central line, you should identify all patient-related issues that become relevant in choosing a site and placing a line safely.
When deciding to place a central line, you always want to pre-scan your site. For the internal jugular vein, you always want to identify the anatomy, which includes the sternocleidomastoid muscle. To identify the sternocleidomastoid muscle, it stretches from the mastoid process of the skull down the anterior lateral surface of the neck, and it splits into two arms. One arm goes to the sternum, and one arm goes to the clavicle. This makes it a triangle, and at the apex of this triangle is where you'll find your internal jugular vein. You always want to scan to make sure that you don't have any clot and that the vein is patent the whole way down. You can tell that the vein is on the right side of the screen. It is thin-walled and compressible, whereas the artery is on the left side of the screen and it is thicker walled and will be pulsatile. If your carotid artery is lying underneath the internal jugular vein, you might want to try a more neutral head position rather than turning the head to the opposite side. This could bring the internal jugular vein out more lateral to the carotid artery. In addition, you want to search for a site where you avoid your needle traversing through the sternocleidomastoid muscle. Now it's time to prepare your environment for placing the central line. You will need numerous supplies from the MICU supply room. The first thing that you're going to need is the critical care bundle. This is located right outside the MICU supply room. It contains 2 gowns, a full set of drapes, and a full set of towels. In addition, inside the MICU supply room, there's a sheet that goes through everything that you will need for a central line and a bag to collect your supplies. If you take supplies from the MICU supply room, you must sign out what central line kit you take and the supplies that you've taken on the clipboard that's hanging. You'll need a bouffant cap for everyone who is in the room, as well as a mask with a face shield or goggles for everyone who's inside the room. You'll need 3 chloropreps to clean the area. 1 chloroprep will come inside your central line kit, so a total of 4 chloropreps. You'll need a ultrasound transducer cover. In some kits, the ones that are lined with plastic, this is on the outside of the bag. In other kits, it's not outside the bag, and you'll need to get this from the supply room. In addition, you'll need sterile gloves, appropriate size for people who are going to remain sterile. You'll need 2 sterile flushes. These are the only sterile flushes that are pre-packaged. Do not take the clear packaged saline flushes, as they are not sterile. In addition, you'll need 1 blood gas syringe to confirm your line. You'll need 3 blue caps to cover the ports of your line. And you'll need 1 BioPatch and a large tegaderm. When placing a line, you want to decide what type of catheter you want to place. There are a couple of different options. One option is a triple lumen catheter. They come in size 16 centimeter and 20 centimeter. 16 centimeter you'll use on a right-sided IJ, 20 centimeter on a left-sided IJ. The triple lumen catheters either come pre-packaged like this in a plastic bag, which will have supplies taped to the back of it, or will not come pre-packaged, in which case it won't have an ultrasound probe cover or sterile saline included in the bag. The triple lumen catheter has a green sheet inside, and you can see that it has 3 different lumens, a 16 gauge lumen and 2 18 gauge lumens. If you're considering dialysis, you might want to place a triple lumen Shiley, which you can do dialysis through, and you also have an extra lumen. The triple lumen Shileys also come in 16 centimeter and 20 centimeter sizes. They also come pre-packaged in the plastic bag, and you can see that it has two 12-gauge lumens as well as one 16-gauge lumen. Finally, you have double lumen Shileys, which don't have the extra lumen. Those don't come pre-packaged, also come in 16 centimeter and 20 centimeter sizes. And finally, you have a percutaneous sheath or an introducer kit, which also does not come pre-packaged.
There are 5 major steps in preventing bloodstream infections. Put on hat, mask, and non-sterile gloves. Prepare the skin with antiseptic detergent chlorhexidine, 2% in 70% isopropyl alcohol. Pinch the wings of the applicator to break the ampule. Hold the applicator down to allow the solution to saturate the pad, and then press the sponge against the skin, applying the solution back and forth for at least 30 seconds. You will repeat this process 2 more times. Do not wipe or blot, and allow the chlorhexidine solution to dry completely before puncturing the site. This is approximately 2 minutes. While you wait for the chlorhexidine to dry, you can create your sterile tray by opening the central line bundle, being careful not to touch anything inside the pack that may be sterile. Place the external items from the pack, such as the ultrasound cover, sterile flushes, BioPatch, Tegaderm, blood gas syringe, central line caps, onto the sterile field. And finally, place your sterile central line kit onto the sterile field. We are now ready to put on your sterile gown and sterile gloves using surgical technique. Prior to initiating putting on the sterile gown and gloves, you must Purell your hands. Open your gloves and lay out in a sterile manner on a clean surface. Grab the sterile gown by the inside under the neck and place and extend your hands through the armholes on either side. Pull your gown on, being careful not to raise your hands above your neck or below your waist. With your hand still on the sleeve of the gown, pinch one glove and slide your hand inside. Now with the unused glove, with your gloved hand, slide your other hand inside. Adjust your fingers and extend the sleeve of the glove up your arm. Have a nurse or helper close the back of your gown. You should now be fully dressed with maximal barrier protection, including a bouffant cap, face mask, gown, and sterile gloves. If at any point you accidentally touch something that isn't sterile, you must start over in applying maximal barrier protection. Your face mask must include an eye shield or face guard. We are now ready to open the package containing the surgical drape. For the purpose of this video, and for Kate's comfort, we will not be wearing surgical masks at this time. Remove the sticker from around the hole and place on patient's neck over previously identified location. Follow the diagram on the drape as well as the arrows and fully unfold the drape. You can have a helper assist in fully unfolding the drape towards the feet. Take your ultrasound probe cover and carefully open the package. Slip the rubber bands over your thumb so you don't drop them. Place your hand in the cover and place a small dab of sterile gel at the tip. Have your assistant hand you the probe and grab it with your hand in the sterile probe cover. Then pull down on the cover to extend over the cord. Finally, place the rubber bands around the top of the probe to keep the cover in place. Drape the covered ultrasound probe over the patient so it remains sterile.
Now we're going to go through the kit, see what's inside, and make sure everything's working appropriately. Inside some of the kits, it comes with a tegaderm, with a gel chlorhexidine pad. Our preference in our ICU is to use a large tegaderm with a BioPatch rather than the gel pad. It also comes with plastic tubing, which we'll discuss later, for manometry. Some gauze. You have 2 vials of lidocaine to anesthetize the skin. You have a small syringe with a 20 gauge and a 25 gauge needle to draw up your lidocaine and to anesthetize the skin. You have 2 different needles to use. The one that I prefer to use is the blue syringe. With this needle, you have to be able to hold it with one hand, so you can control the ultrasound with one hand and your needle with the other. So I like to hold it with my fingers against the plunger and my thumb against the actual syringe, so I can pull back with my fingers without having to use an extra hand. The other needle that comes with the kit has a white catheter at the end of it. This is a thinner gauge needle. You can use it in patients who are coagulopathic. You can also use it in patients who are moving around a lot or in an emergent or code situation where you don't want to leave a needle in the patient. With this needle, when you actually get blood flow, what you're going to do is squeeze here and twist off. You want to make sure it's not put on too tightly, or it'll be difficult to twist off in a gentle manner. So nice and gentle on. When you twist off, you should have blood flow and you'll insert your wire here. The difference with this catheter is that you can't twist off and thread your wire through because it's a smaller caliber needle. In order to thread your wire with this catheter, you would have to get blood flow in the same manner with your fingers here pulling back. And once you get blood flow, you would just take your catheter and you would advance your catheter off the needle into the vein. And then take your needle off the field. This would be in the vein, and you would put your wire through this catheter. We can also use this catheter as a means to manometry, which we'll discuss at the end. In addition, in the kit, you have your wire. The wire has a plastic cap at the end, which you'll need to pull off. And this will expose your wire, which has a curved end. You want to make sure that you can straighten your wire by pulling it back with your thumb into this blue cap in order to be able to place the wire in and advance it with your thumb. You also have a scalpel and a dilator in order to dilate your vessel. And finally, you have your actual catheter. It has 3 lumens, a blue, a brown, and a white. You're going to take the caps off of all of these. and flush them with sterile saline. This ensures that the catheter is working correctly. And then you want to clamp it off. This instills sterile saline into each lumen and decreases the risk of air embolism as you insert the line. So you're going to flush each port and clamp it off. You also have two clamps that come in the kit. A white rubbery clamp that when you squeeze open has a slit at the end, and a blue plastic clamp. If you place a line and you don't want it to go all the way in, you want to leave some room because you think it'll be too deep, you can place this white cap over your catheter by squeezing it on, and then place your blue cap over it, making sure that your holes line up, so that when you suture the line in, you can suture here and here, making it a shorter line, and you would do this after the line is placed. And then finally, you have a curved stitch, you have a needle driver, and you have a scissor to stitch your line in at the end. So first we're going to draw up some lidocaine. Now we're going to apply some sterile gel to the patient's neck and find our site with the ultrasound. You want to make sure when you're using the ultrasound that the way you're holding the ultrasound is physiologic to the way that it's appearing on the screen, so that the left side of your ultrasound probe is going to be the left side of your screen. And again, if this were in a real patient, I would have, since I'm doing a right IJ, I would have my ultrasound over here so that I'm aiming towards the ipsilateral nipple, rather than positioning myself in this position where I'm kind of aiming across the table. So we're going to get our vein and our artery into view, and you see that the vein is on the right side of the screen. It's thin-walled and non-pulsatile and compressible, whereas on the left side of the screen we have a thicker-walled artery that is pulsatile. So we're going to center the vein in the middle of our screen. The middle of our screen is also represented by a line on the ultrasound probe, which shows that the middle of the ultrasound probe is the center of the screen. Okay. So we're ready to begin. You're going to hold the ultrasound probe with your non-dominant hand preferably, so my left hand, and place it on the patient. I have the vein centered on the screen, and I'm going to anesthetize the patient with some lidocaine. I'm going to make sure that I'm not anywhere near the vessel. I'm going to pull back on my syringe first, and then give some anesthesia to the surface of the skin, making sure that the patient is numb. I like to do my central line in 3 different steps so that I remember clearly what I'm going to do in each step. For my first step, I'm going to need my needle, I'm going to need my wire that's all set up, and I'm going to need my blood gas syringe. We use the blood gas syringe in order to confirm that we're actually in a vein and not in an artery. We also confirm using ultrasound, ultrasounding the wire to make sure that it's in an appropriate place. And at the end, we'll talk about manometry and transduction. So I have everything nearby. I have my wire. I have my blood gas syringe. I've got my needle. I can hold it in one hand. I'm not attached too firmly, so I'll easily be able to twist off. And I'm going to use what's called the creep technique in terms of my ultrasound. There's 2 different techniques. One is called the drop down, or using triangulation. In that method, you're using your ultrasound and you're directing it relatively straight down on the vessel. You want to make sure that left is left and right is right. Otherwise, your anatomy will switch around. So now this is correct. I'm going to center my vein. I'm going to enter at almost a 45-degree angle, a little bit caudal to the ultrasound probe, and I'm going to insert my needle until I see it come into view on the machine in the vessel. And I should have flow of blue fluid. I can see that my needle is in the center of my vein. With the creep method with ultrasound, I prefer it because you're able to basically walk the tip of your needle into the screen. And so the way that you're doing that is instead of directing your ultrasound probe straight down, you're actually holding it so it's angled a little bit towards you on the surface. And when you take your needle with it angled a little bit towards you, as you go into the skin, you're going to catch the needle as it enters the skin. So I see the tip of my needle there. I'm going to angle my ultrasound probe down further so I lose my needle, and then I'm going to advance my needle a little bit further until it enters the screen. I'm going to angle my ultrasound probe away again until I lose the tip of my needle. I'm going to advance my needle further, and I'm pulling back on my plunger the entire time, providing vacuum suction. And then I'm going to walk my tip of my needle directly into the center of the vein, and as I'm pulling back I can see that I have nice good flow of blue fluid, which represents venous. Now I'm going to drop my ultrasound, just rest it. I'm going to brace my hand, pinch the end of this needle, and gently twist it off. At this point, I should have nice, slow, dark red blood flowing back. I'm going to attach my blood gas syringe and get a sample. Once I have my sample, I'm going to take my wire and I'm going to nice and smoothly thread it down. If I meet any resistance, I can drop the angle of my needle so it's more flush against the skin and decrease the angle going into the skin and into the vein. My wire is advanced nice and smooth. I'm between 2 and 3 marks on the wire. I'm going to carefully take the end off, making sure to keep this sterile. And I know I'm in far enough. There's plenty of wire in this kit. You can see there are 3 marks over here on the wire, and I'm just past 2 marks in, so I know I'm in the appropriate length. And now I can take my needle out of the patient, being careful to never let go of my wire, and remove my needle from the field. My wire is now in place. I'm at a very stable portion of the procedure. I can hand off my venous blood gas to a nurse or a helper to go run in our MICU machine or to send down to the lab. In the MICU, we like to confirm our blood gases to ensure that it's venous before we go on with the procedure dilating the vessel. Another way of confirming that we're in the vein is ultrasounding the wire as it goes in. So I'm going to take my ultrasound probe, I'm going to place it at the surface of the skin as my wire goes in, and I'm going to scan down until I see my wire traveling down into the vein and sitting in the vein and not in the artery. We can then take a picture and freeze this image and print it out, tape it to the back of the patient's consent, and then when we write our procedure note, we can say that the ultrasound image was stored in the patient's chart. Once we are confirmed that we are in a vein with our blood gas and our guide wire, the next step in my central line placement, I use a dilator and a scalpel. The scalpel is just to make a nick in the patient's skin so that the dilator doesn't get stuck as it goes and advances over the wire. You want to take your scalpel with the dull side down, hold your wire out a little bit, and what you're going to do is clean the surface and make a small nick just as the wire enters the skin. Being careful not to cut the wire, and also being careful not to leave a skin tag. A skin tag occurs when, if you imagine your wire going into your skin, when you take your scalpel and you go down, if you're not right up against the wire and you make a nick over here, you end up with a hole from your scalpel over here, a tag of skin, and your wire here. So when you advance your dilator, you're actually not advancing it into a larger hole. Now that we have a small opening in the skin, I'm going to take my dilator and place it over the wire. Again, making sure never to let go of the wire. And as I advance my dilator, I want to make sure that I'm not coming at the surface of the skin at a sharp angle, that I'm really flush against the skin in the way that the vein travels. I'm going to grab the dilator around halfway down and nice with smooth pressure, dilate from the skin down into the vessel. You only have to go around halfway down in most patients. When you come out with your dilator, you might want to have some gauze ready because you should have some more blood flow as you've just dilated your vessel to the surface. You're going to remove your dilator, still holding on to your wire. For the last part of your procedure, you need your actual central line. All of the ports are clamped off and flushed with sterile saline right now. And you're going to place the central line over the wire. As you thread your wire back, keep in mind you have plenty of wire here. You're going to unclamp your brown port, which is where the wire is going to come through. And as you get to the surface of the skin, you're actually going to pull back on your wire. You never want to let go of the wire until it comes out from the brown port. Then you grab it at the brown port. And again, in the direction that the vein is going, nice flush against the skin, you can advance your catheter into the vessel. Once your catheter is in place, you're going to be sure to remove your wire. This is a very important step. You're going to take your sterile saline and attach it to the brown port. At this point, because it is such an important step to take your wire out, and because it otherwise will kind of flop around on your field, I like to tie my wire in a knot, kind of as a reminder that I've taken my wire out of the patient, and then I can remove it from the field. Next, when I flush the lines, I want to make sure that I pull back on them, that all of the lines draw back nicely and flush. So I'm going to give some slight pressure up. I like to hold my syringe vertically so that if there's any air bubbles in the line, they're going to rise to the top and I won't flush them back in. And in a normal patient, you would get some nice red blood coming back, and just before it fills the syringe, you want to flush that through. And then before you twist off, you're going to clamp off. And you're going to do that for each of these lines. And then you're going to secure the ends of these lines by placing your blue cap over each. And then doing the same procedure again of pulling back and flushing through. So our line is now in place and we just have to secure it in place. Again, on the right side, you should be inserting a 16 centimeter catheter. On the left side, a 20 centimeter catheter. For some patients, a 16 centimeter catheter or a 20 centimeter catheter is going to be too long. If that's the case, that's when you would use these white and blue clamps. You would pull the line out to the desired length, which is measured by two black lines and then black dots. The two black lines represents 20 centimeters on a 20 centimeter and 16 centimeters on a 16 centimeter kit. Each dot further in is 1 centimeter down. So if I wanted to secure this line, which happens to be a 20 centimeter line on the right side, you would pull back until the desired length, clamp on your white rubber catheter and then clamp on your blue plastic cap after. And then when we stitch this in place, we would find positioning so that we could stitch here and here and give it a little curve here and here. You wouldn't want to make too tight of a curve because it would be hard to overcome the resistance. So a nice gentle curve. This also allows you, after you've confirmed the line and placement with a chest x-ray, if you need to pull back on the catheter, you could take down your dressing wearing sterile attire, and instead of having to deal with anything at the insertion site, if you wanted to pull it back 2 centimeters, you could just grab right here, hold tight, and extend your loop a little bit without having to unstitch in either part, and then reapply your tegaderm. So our catheter is now in place. I'm not going to stitch it down, but if I were, I would be stitching it down in all 4 points over here to make sure that it's nice and secure. I might have to pull back a little bit on the plastic drape in order to be able to stitch this to the skin. I'm then going to clean the area, get any gel or blood off the area. And for this last step, I'm going to apply my BioPatch. So the BioPatch has 2 sides. There's a blue side that says up on it, and there's a white side. You're going to place it so that the blue side is up. You can use your needle driver to help you get it around the catheter. And so what you can do is pull back a tiny bit on the catheter, use your needle driver to help slide it underneath the stitch, and pull it around the side. So that it will end up sitting like this. We're going to clean the whole area with your last ChloraPrep. The ChloraPrep that comes in the kit is actually dyed orange, so sometimes I'll trade out the orange ChloraPrep for a clear one. Make the area look nice and pretty. We're going to let it air dry. And then once it's dry, we can pull up a little bit on the plastic to make room for our tegaderm, but we don't want to take all of our sterile field off before we place our tegaderm. So we'll make a little bit of room. We'll get our tegaderm without the gel. And we're going to place so that the clear part is over the entry, securing the line in place. So before we finish, just some pointers for troubleshooting on difficult lines. If you have a patient who has very collapsible veins, who's very under-resuscitated, the first thing you can do is place them in Trendelenburg, which is having their feet angled into the air and their head closer to the ground to allow for more venous filling. Another thing that you can do in a patient who you might not be able to put all the way in Trendelenburg, if the patient is awake, you can ask them to hum while you place the line. Humming will increase their intrathoracic pressure and will decrease venous return, which will plump up their internal jugular vein. On a ventilated patient, you could wait for a ventilator-given breath, which will have the same effect of increasing the intrathoracic pressure and decreasing venous return. When you're actually placing the catheter, when you insert your wire, some people insert their wire a little aggressively, and you have to keep in mind that putting the wire in too far can tickle your right atrium, inducing a dysrhythmia. The patient should always be on a monitor, a cardiac monitor, so that you can tell if the patient goes into a different rhythm. If they start having extra beats or an irregular rhythm or a change in their rhythm, you want to make sure to pull your wire back so that it isn't in as far. Finally, there are 4 ways to confirm your catheter placement. The first way we demonstrated was drawing blood gas off of the catheter or off of the needle as you place your line to ensure that it's venous. The second way is ultrasounding your wire to ensure that it's sitting in the vein and not in the artery, and you can take a picture of that to record it. The third way is something called manometry. In some of the kits, it comes with a clear tubing, and what you can do is after you've obtained access to the vein and you have your wire in, if you haven't used the needle with the white catheter on the end, what you can do is place this needle over the wire. The way that you would do that is, if you have your wire sitting in the vein, you would just take, before dilating, your white catheter and place it over the wire until it's hubbed against the skin. Then what you can do is withdraw your wire back into its holder, leaving your catheter in place. You should then have non-pulsatile dark blood flowing back through your catheter. At this point, you can attach your clear tubing. You would hold it flat, allowing dark red blood to flow into the tubing, and then you would raise the catheter up. And what you would expect to see, if it was an arterial stick, you would have an arterial pulsation in the tubing, potentially going out of the tubing. If it's venous, you would have dark red blood, and you wouldn't see an arterial pulsation. You just might see some mild respiratory variation, and it shouldn't extend past. The fourth way to confirm is by attaching this white catheter to the monitor to transduce a pressure and a venous waveform. Once you've accomplished confirming your line by two of the methods, usually by blood gas and by ultrasound of the wire in the medical ICU. If you used manometry or transduction and you had this catheter in place, you would then again take your wire, which is now back in its holder, and advance it again through this catheter. Once your wire is in place again, you would withdraw your catheter and go on with the rest of your steps using your scalpel and your dilator, and then finally putting your catheter over and withdrawing your wire. So one final complication you should be aware of would be pneumothorax. After you've placed the line, if the patient becomes unstable, becomes hypotensive, if they're on the ventilator and they have high peak pressures, you would be concerned that you might have caused a pneumothorax. Ways to evaluate for this emergently is listening with a stethoscope for breath sounds, or using your linear probe on your ultrasound to assess for lung sliding. These are our steps for placing a sterile central line. Thanks for watching.